Whole thyroid is removed, patients need hormone replacement, right?
Absolutely. Patients who've had a total thyroidectomy will need to take levothyroxine, which is synthetic thyroid hormone, for life to replace what their gland used to make.
Just standard replacement.
Well, yes, but interestingly, it's often given at a dose that's slightly higher than just pure replacement. The goal is to suppress the level of thyroid-stimulating hormone, TSH, from the pituitary gland.
Why suppress TSH?
Because TSH can actually act as a growth factor for thyroid tissue, including any potential remaining differentiated thyroid cancer cells. So keeping TSH levels low helps reduce the risk of the cancer coming back or recurring.
So you're replacing the hormone the thyroid made, but also using that replacement strategically to suppress something that could potentially fuel any leftover cancer. That's clever.
It is. It's called TSH suppression therapy.
Okay. What about other types of radiation, like external beam radiation?
External beam radiotherapy, or EBRT, is used less often than surgery or RAI for thyroid cancer overall, but it has important roles. It's a key part of treatment for the very aggressive anaplastic carcinoma.
Right, because surgery and RAI don't work as well there.
Correct. It's also used for tumors that couldn't be completely removed by surgery or for treating metastases, especially bone metastases, that don't take up radioactive iodine.
Okay. And for advanced cases, maybe where the cancer has spread widely or come back and isn't responding to RAI anymore, what options are left then?
This is where targeted therapies have really made a difference in recent years, especially for certain types. These are drugs designed to specifically attack molecular pathways that the cancer cells rely on to grow and survive.
Can you give some examples?
Sure. The notes list several. For differentiated thyroid cancers that have become refractory, meaning they no longer respond to radioactive iodine, drugs like sorafenib and lenvatinib can be used.
Okay.
For metastatic medullary carcinoma, specific tyrosine kinase inhibitors like vandetanib and cabozantinib are options.
Targeting pathways important in medullary.
Exactly. And connecting back to that genetic testing we discussed, for anaplastic carcinoma that has the BRAF V600E mutation, the combination of dabrafenib plus trametinib, which target that specific pathway, can be used.
Wow, so the specific genetic tests we talked about earlier can directly determine which of these targeted drugs might actually work for a patient. That really shows how personalized treatment is becoming.
It absolutely does. It's moving away from one-size-fits-all towards treatments tailored to the molecular profile of the tumor. And chemotherapy, traditional chemo, also has a limited role, mainly used in anaplastic carcinoma, sometimes alongside radiation, with drugs like paclitaxel or doxorubicin.
Okay, so